Today is the seventh long case webinar series. And Dr. Upul De Silva is the consultant general and HPB surgeon and senior lecturer in surgery and head of the department from the Faculty of Medicine, Sabaragamu University. And he's going to discuss about the gallstone disease. And I think he's planning to get a history from the student and then the possible discussion and then the something about the gallstone disease. And at the end, you can ask or text, or it's better to ask the question rather than texting. So whatever the mean, you can ask any question from him. And over to you, Upul.
Thank you, Dr. Anurad, for the kind introduction, and good evening, everyone. So, as Dr. Anurad said, we are going to discuss a long case about the gallstone disease, and this is the plan. So, we'll start with the observed history taking, and then we'll go ahead with the discussion. There, I will try my best to discuss the possible questions that you can be asked in a scenario like this and try to give some discussion points for these questions. And then I'll give two model, one model MCQ and one model SBA in this particular section of the surgical curriculum. And then I'll be happy to answer if you have any questions. So Dulhan was is happy to take the history. I'll be the patient. I think you all are very thorough with the timing and all in the examination. So I'll let him take history for 10 minutes and examination for 5 minutes. If Dulhan is ready, we can carry on.
Sure, sir. මහත්මයා මම අවසාන වසර වෛද්‍ය ශිෂ්‍යයෙක් මේ සැරේ මහත්මයා හොස්පිටල් එකට ආවේ මොකද කියලා ඒ සම්බන්ධයෙන් ප්‍රශ්න ටිකක් අහලා විස්තර ටික දැනගන්න තමයි මම ආවේ මේ වෙලාවේ උත්තර දෙන්න පුළුවන්ද කොහොමද
ප්‍රශ්නයක් නැහැ අහන්න ප්‍රශ්න
මහත්මයාගේ නම මොකද
මම නිමල්
වයස කොහොමද මහත්මයා
අවුරුදු 65ක් වෙනවා
මහත්මයා ගම කොහෙද ගෙවල් තියෙන්නේ
කහවත්තේ මේ රත්නපුරේ පැත්තේ කහවත්තේ තමයි ගම. ඔව් එහෙ තමයි මම දිගටම ජීවත් වුනේ.
දැන් මොනවා හරි රැකියාවක් කරනවද
දැන් නම් රස්සාව කරන ටිකක් අමාරුයි මේ වයසයි මේ අසනීපයි එක්ක මේ මම කලින් ටීචර් කෙනෙක්. මම ඉගෙනුවා මේ O level ගණිතය ඉගෙනුවා දැන් මම රිටයර්ඩ්.
මේ සැරේ හොස්පිටල් එකට එන්න හේතුව මොකද්ද පොඩ්ඩක් විස්තර කරන්න
නේ මගේ මේ බඩේ බටයක් දාලා තිබ්බනේ මේ ඒක මේ පෙන්වන්න තමයි මම අද ආවේ නැතුව මට විශේෂ අමාරුවක් දැනට නැහැ මට එන්න කිව්වා මේ පොඩ්ඩක් මේ බටේ පරීක්ෂා කරලා බලන්නයි මගේ මාව පරීක්ෂා කරන්නත් ඕන කියලා මේ මාසෙකට කලින් විතර තමයි මේක දැම්මේ
හරි මේ මාසෙකට කලින් මොකද වුනේ ඒ කියන්නේ මේ හැමදේම පටන් ගන්න මාසයයිද වෙන්නේ නැත්නම් ඊට කලින් ඉඳන් මේක තියෙනවා
මෙහෙමයි මට නිකන් බඩේ කැක්කුම නම් ටිකක් කල් වෙනවා ඇත්තටම බඩේ කැක්කුම මාස 6ක් 7ක් වෙනවා සැරින් සැරේ ආවා මේ බඩේ උඩ හරියේ කැක්කුම එනවා සැරින් සැරේ මේ එතකොට මම ඉතින් ওই ළඟ ડોක්ටර් කෙනෙක්ගෙන් බෙහෙත් ගත්තා පස්සේ ස්කෑන් එකක් කරමු කියලා ප්ලෑන් කරන් හිටියා එතකොට තමයි මේ ගිය මාසේ මේ හොඳටම අමාරු වෙලා මාව ඇඩ්මිට් කරේ කහවත්තට කහවත්තෙන් රත්නපුරයටත් එවුවා ඊට පස්සේ අමාරු වැඩි වෙලා එතකොට තමයි මේ බෙහෙත් ඉදලා හරියන්නේ නැති කම තමයි බටේ දැම්මේ
හරි. එතකොට මේ මම බඩේ කැක්කුම ගැන දැන් පොඩ්ඩක් අහන්න විස්තර. බඩේ කැක්කුම කොයි හරි වගේද තියෙන්නේ? ඒ කියන්නේ තැනක් ඒ කියන්නේ පෙන්වන්න කියන්න පුළුවන්ද? නැත්නම් මුළු බඩම වගේද?
ඒ කියන්නේ මහත්මයා අහන්නේ මේ මාසයකට කලින්ද ඊට කලින් කැක්කුමද?
මේ ඔක්කොම පටන් ගන්න දැන් කොච්චර කාලද?
මාස 6ක් විතර වෙනවා.
මාස 6ක් විතර වෙනවා. ඒ මාස 6 ඉඳන්ම එකම තැනද දෙන්නේ නැත්නම්
මුලින් බඩේ කැක්කුම ආවේ මේ බඩේ උඩ හරියේ මේ ටිකක් දකුණු පැත්තට වෙන්න තමයි මේ ඒක ඇක්කුම මේ සැරින් සැරේ තමයි ආවේ. ආවම ඉතින් පැය භාගයක් පැයක් විතර තියෙනවා. ටිකක් පැන්ඩෝල් බිව්වම එහෙම අඩු වෙයි තමයි තිබ්බේ. ටික ටික ඉතින් මේ කියන මාසයකට එකපාරක් දෙපාරක් හැදුනා ඒක ඇක්කුම. මුලින්ම හිතුවේ ગેස්ට්‍රයිටිස් කියලා. පස්සේ හිතුවා මේ ස්කෑන් එකක් කරන්න ඕන කියලා මේ ප්ලෑන් කරලා තිබ්බා මම මේ ක්ලිනික් එකට එවලා. එතකොට තමයි ගිය මාසේ හොඳටම බඩේ කැක්කුම මාරුනේ වෙනදනම් අඩු වෙනවනේ ගිය මාසේ අඩු වුන්නේ නැහැ කැක්කුම. දිගටම තිබ්බා මේ හොස්පිටල් එකට ඇවිල්ලා බෙහෙත් විදිනකම් කැක්කුම.
හරි. එතකොට එක පාරම තමයි මේ කැක්කුම එන්නේ නේද? ටික
ඔව්
ටික ඇවිල්ලා වැඩි.
ඔව් ඒ කියන්නේ පෑ භාගයක් වගේ එනවා එකපාර තමයි එන්නේ නැහැ හැම අපිට වෙලාවක් කියන්න බෑ ඉතින් ටිකක් කෑවහම වැඩි ටිකක්.
හරි. එතකොට මොන වගේ කැක්කුමක් දෙන්නේ? නිකන් තද කරනවා වගේද, අනිනවන්නා වගේද මොන වගේ කැක්කුමක් දෙන්නේ?
ටිකක් තද කරනවා වගේ තමයි එන්නේ නිකන්. අල්ලනවා අතාරිනවා වගේ නිකන් තමයි එන්නේ මේ ටිකක් වෙලා තියෙනවා.
ඒ කැක්කුම කොහාට හරි යනවා වගේ පල්ලෙහාට හරි පිට මැද්දට හරි මේ
ඒක
අත
මේ
දිහාට
සමහර
යනවා
වෙලාවට පිටපැත්තටත් යනවා. මේ අර හොඳටම අමාරු වෙලාව නම් මේ මගේ උරහිස පැත්තටත් අමාරු වුණා පොඩ්ඩක් මේ කොන්දටයි මේ
කකුල්.
මගේ දකුණු පැත්තේ උරහිස පැත්තට එහෙමත් ආවා. මේ
හරි.
ගොඩක් අමාරු ණා ඒ පාරන.
හරි. මේ එතකොට මේ ගොඩක්ම අමාරුනේ මේ අන්තිම මාසේ නේද?
මේ අන්තිම පාර ආපු මේ වෙලාවේ තමයි ගොඩක්ම අමාරුනේ.
කලින්. එතකොට මේ දැන් මේ මාසය ඇතුළත දිගටම පොඩි හරි කැක්කුමක් තියෙනවා මේ අඩුම වෙන්නේ නැහැ නේද? කැක්කුමක් නැතිම අවස්ථාවක් නැහැ.
මේ මාසේ නම් මට කැක්කුම ආවේ නැහැ මේ බටේ නිසා. හැබැයි ওই මහත්ය කෙනෙක් කලින් තිබ්බා දැන් මේ මාසෙට
කලින්
කලින් කැක්කුම එනකොට මේ අර වගේ තමයි ටිකක් දිගටම තියෙනවා පෑ දෙකක් තුනක් ගියාම අඩු වෙලා යනවා ඉබේම.
යනවා.
හැබැයි ගිය
හරි.
මාසේ ආපු කැක්කුම නම් එහෙම අඩු වුන්නේ නැහැ.
අඩුවම. එතකොට මේ කැක්කුමත් එක්ක නිකන් ඔක්කාරට එන ගතියක් කෑවහම නිකන් වමන යන්න එන ගතියක් වගේ මොන හරි තියනවද?
එහෙම ටික ටික තිබ්බා. මේ ගිය
හරි.
මාසේ නම් මට හොඳටම වමනේ ගියා.
උණ එහෙම තිබුණාද?
ගිය මාසේ නම් උණ ආවා මේ ඇඩ්මිට් වෙච්ච පස්සේ දෙවෙනි දවසේ ඉඳලා මම හොඳටම උණ ඇවිල්ලා මේ දාඩිය දාලා මට හුස්ම ගන්නත් ටිකක් අමාරු වෙලා මේ පස්සේ මේ දැඩි සත්කාරයකටත් දැම්මනේ මාව මේ අමාරු වෙලා උණත්
හරි.
එක්ක බෙහෙත් වලට අඩු වුන්නේ
එතකොට මේ කාල පරිච්ඡේදය ඇතුළත ඔය මාස 6-7ක් වෙන එක ඇතුළත කෑම අරුචියක් මේ ගොඩක් නිකන් මේ බර අඩු වීමක් වගේ එහෙම තේරිලා තියෙනවද?
නෑ බර අඩුනේ නම් මේ ලෙඩ වුණාට පස්සේ මේ ගිය මාසේ මම මේ බටේ එහෙම දාගත්තට පස්සේ නැත්තම් කලින් නම් එහෙම කෑම අප්පිරියාවක් නම් මට තිබුණේ නෑ කන්න පුළුවන්කම තිබ්බර කෑවම ඉතින් බඩේ දින සමාල්ලාට මේ ටිකක් ඔය වැඩිපුර පිටි එහෙම කෑවම
හරි. එතකොට මේකත් එක්ක මේ টয়ලට් යන එකේ මොකක් හරි මේ වෙනසක් වෙනදට වඩා මේ නිකන් දියර ගතියට යන ගතියක් එහෙම මොනවා හරි තාර කළු පාට යන වගේ එහෙම ගතියක් තියෙනවද?
එහෙමනම් මට තේරලා නැහැ වැඩි.
මේකත් එක්ක නිකන් අර මේ සාමාන්‍ය අපි ગેස්ට්‍රයිටිස් කියන ඒකට එන උගුරට එන ගතියක් සාමාන්‍ය කොට්ට දෙක තුනක් තියලා නිදා ගන්න ඕන ගතියක් එහෙම තියෙනවද? කෑවට පස්සේ අමාරුයි ඊට පස්සේ හරියනවා ඒ වගේ?
එහෙම නිකන් උගුරට ඇවිල්ලා ගතිය නම් තියෙනවා. එහෙම ඔය කියන තරම්ම එහෙම ලොකු ප්‍රශ්නයක් තිබුණ නැහැ මට ඇත්තටම.
මොන වගේ දේවල් කරාමද මේ කැක්කුම අඩු වෙන්නේ? ඉස්සරහට නැවුනහම හරි නැත්නම් මොනවා හරි බෙහෙතක් ගන්නම ඕනේද? ඔය මාස 6
කලින් නම් එහෙම මේ මුල් කාලේ නම් එහෙම නිකන් අර පෑද්දයක් තිබිලා බෙහෙත් බොම අඩු වෙනවා. මේ අන්තිම පාර ආපේ එකේ නම් කොහොම හිටියත් ඉන්න බෑ හොඳටම අමාරු වුණා.
හරි. දැන් මේ අන්තිම පාර ICU ඇඩ්මිට් කරාට කලින් කී සැරයක් හොස්පිටල් ඇඩ්මිට් වෙලා තියෙනවද?
හොස්පිටල් එකට නම් ඇවිල්ලාම නෑ මේ මොකද අර ළඟ ડોක්ටර් කෙනෙක් මම ගත්තේ. ඊට පස්සේ ආ ස්කෑන් එක කරගන්න ක්ලිනික් එකට එව්වා. හැබැයි ස්කෑන් එක කරගන්න බැරුණා මේ අමාරු වුණා මට.
හරි. එතකොට මේ රෝගී තත්ත්වයේ තියෙන ටිකේ ඇස් කහ වෙලා නිකන් කසන්න අරගෙන මේ ඒ වගේ මොන හරි ඇවිල්ලා තියෙනවද? ටිකක් ඇඟ කහ වෙලා කවුරු හරි කියලා.
ඇස් කහ වුණේ නෑ මගේ කවදාවත්.
මොකුත් නෑ. මේ මුත්‍රාවල පාට තද පාට ඇවිල්ලා කිරිමැටි පාට টয়ලට් යන්න අරගෙන එහෙම මොකුත් නෑ.
මුත්‍රා නිකන් ටිකක් අද පාට නෑ උනාට එහෙම ලොකු එහෙම මට එහෙම තේරුනේ නෑ. කවුරුත් කිව්වෙත් නෑ මට.
හරි. මහත්තයා මේ මත්ද්‍රව්‍ය මත්පැන් එහෙම පාවිච්චි කරනවද? අරක්කු සිගරට් ඒවා
ඉඳලා
පාවිච්චි
හිටලා ඉතින් ඔය පාටියක් තිබ්බොත් නම් අරක්කු ටිකක් බොනවා ඉතින් මේ බියර් වගේ තමයි බොන්නේ. මාසයක් දෙක මාසයකට සැරයක් දෙකක් තමයි එහෙම ලොකුවට නම් බීලා නැහැ ඉතින් දිගට.
සිගරට් එහෙම වැඩි එහෙම
සිගරට් නෑ බීලා බොන්නෙම නෑ මම.
බොන්නෙම. හරි. එතකොට මේක හින්දා මේ එදිනෙදා වැට්ටික් කරගන්න බැරි තරමටම අමාරු නා නේද? ගිය මාස ටිකේ.
ගිය මාසේ තමයි ඇත්තටම අමාරුනේ. මෙහෙමයි මට කොහොමත් ටිකක් අසනීප තියෙනවානේ මට සීනි ප්‍රෙෂර් යනම නම් තියෙනවා. ඒවත් එක්ක අමාරුකම තිබ්බා. දැන් මේ ගිය මාසේ අමාරු වෙනකන් ඉතින් මම මගේ වැඩ ටික කරගත්තා.
කරගත්තා.
අ,
ගිය
මේ
මාසේ
ගෙදර
තමයි
ඉතින් පොඩි පොඩි වැඩ කරනවා.
හරි. එතකොට මේ දැන් මේ ගිය සැරේ ඇඩ්මිට් වුණාට පස්සේ මොකක් හරි සැත්කම මොන හරි කරන්න තියෙනවා හරි ඒ වගේ මොන හරි විස්තරයක් දැනුවත්කමක් තියෙනවද කියලා.
ගිය සැරේ ඇඩ්මිට් වුණාමනේ දැන් අර මේ මම හොඳටම අමාරු වුණානේ. ඒතකොට මට බෙහෙත් ඉදලා මේ බැරිම තැන මේ තමයි ડોක්ටර්ස්ලා මේ තීරණය කරේ බටයක් දාන්න ඕන කියලා.
හරි.
මේ ඊට පස්සේ මේ අර මට මේ අර මගේ කලින් heart attack එකක් ඇවිල්ලා තියෙනවනේ අවුරුදු දෙකකට කලින්. ඕකත් එක්ක මට
හරි.
හුස්ම ගන්න අමාරු වෙලා ඔය මේ මට උණ වැඩි වුණාට පස්සේ තමයි මාව මේ ICU එකට මගේ පොඩක් කල්පනාවක් වෙනස් වුණා කියලා කියනවා. ඊට පස්සේ මාව ICU එකට දැම්මා. රත්නපුරේ.
හරි. හා
එතකොට
හා
තමයි ඔය මේ බඩට බටයක් දැම්මේ මේ ස්කෑන් කාමරේදී.
හරි. සීනි හැමක් තියෙනවා කිව්ව නේද? සීනි කොලෙස්ටරෝල්
ඔව්.
ප්‍රෙෂර් මොනවද තියෙන්නේ?
ඔක්කොම තියෙනවා. සීනි, කොලෙස්ටරෝල්, ප්‍රෙෂර් අවුරුදු දෙකකට කලින් heart attack එකක් ආවා.
හ්ම්.
ඒ ටික තමයි මම අර බෙහෙත් බොනවා ක්ලිනික් යනවා.
මේ ඒවා මේ කන්ට්‍රෝල් වෙලා තියෙනවද බෙහෙත් වලින් නැත්නම් අඩු වැඩි වෙනවද?
ඔව්. එහෙම ප්‍රශ්නයක් තිබුණේ නැහැ මේ ගිය පාර අර අමාරු නම් මං හිතන්නේ මේ විස බීජෙත් එක්ක තමයි මේ ඔක්කොම මේ ගතිය වැඩි උනේ. හැබැයි දැන් නම් ටිකක් ආයේ ප්‍රශ්න අඩුයි.
හරි. ලේවල් සම්බන්ධ අසනීප මොන හරි තියෙනවද? ලේ අඩු වෙලා ලේ දෙන්න වෙලා එහෙම මොන හරි?
නෑ මට එහෙම තිබිලා නෑ.
පවුලෙන් අසනීප මොන හරි තියෙනවද මහත්තයා? අම්මට තාත්තට සහෝදර සහෝදරයන්ට?
සීනි කොලෙස්ටරෝල් තියෙනවා වෙන නන් නැහැ.
හරි. ඇලර්ජිස් මොන හරි තියෙනවද? කෑම් වලට, බෙහෙත් වලට,
අ,
ප්ලාස්ටර් වලට?
නෑ.
හරි. එතකොට මේ කවුරුද ගෙදර ඉන්නේ දැන්?
නෝනා ඉන්නවා ළමයි දෙන්නෙක් ඉන්නවා එයාලා නම් මේ දැන් රස්සාව කරනවා එහෙම ප්‍රශ්නයක් නැහැ ඉතින්.
ආහා. ඒ කියන්නේ මුදල් එහෙම දැන් ජොබ් එක කරන්න බැරි වුණාට එහෙම ගැටලුවක් නැහැ. ඒ කියන්නේ ඒ මොන හරි
ඕ නෑ
තියෙනවද?
එයාලා බලා ගන්නවා පුතාලා බලා ගන්නවා.
හරි. අ, එතකොට දැන් මේ සැරේ මොන හරි මේ අමාරුකම් තියෙනවද? අලුතෙන් මොන හරි අමාරු තියෙනවද?
මේ මොහොතේ නම් ඉතින් ඇත්තටම කියන්න අමාරු නෑ මේ බටේට මොකද කරන්නේ කියලා තමයි මට දැනගන්න ඕනේ. මේ බඩේ
හරි.
එකක්ම නම් අඩුයි. උණ එහෙමත් දැන් එන්නේ නැහැ. දැන් අර මේ මම සතියක් එකමාරක විතර ඉඳලා ගෙදර ගියාට පස්සේ ප්‍රශ්නයක් උනේම නැහැ. මේ
හරි.
අද එන්නේ කිව්වේ ඒක බලන්න තමයි මං හිතන්නේ.
හරි. Okay.
So you have 5 minutes for the examination. So this is the abdomen, but you can ask me what do you want to know, so I'll tell you.
Okay, so first in this patient, I'd like to start with the general examination, check whether the patient is febrile, pale or not, and also check the temperature using a thermometer and look for any nutrition deficiencies like angular stomatitis or bursitis, and also check for finger clubbing and ankle edema. And in the abdominal examination, I would like to see in the inspection whether the abdomen is distended or not.
Yes,
And
yeah, carry on.
and any visible masses and also previous surgical scars. And also, I would like to inspect the insertion site of this tube, whether it
Mm-hmm.
infected, there's erythema and like leakage of bile or any inflammatory changes. And also I'd like to check the tube, whether it is patent, kinked, blocked or not, and also see for the bag and the content, whether the color is usual as the bile and like or it is containing with pus or blood. And also in the palpation, I would like to see for any tenderness in the abdomen and uh, for organomegaly, hepatomegaly and splenomegaly, and also for the palatable kidneys. And in the auscultation, I'd like to see for the bowel sounds and for the renal and hepatic bruise, if there's hepatomegaly, hepatic bruise, and also the renal bruise.
Yeah, as I think you can see the screen, yeah? So
Yes.
can you, yeah, so you can, I have put up some details. So in addition about the drain is, do you want to know the volume you said?
Yes, sir. I want
Yeah,
to.
it's about 5 to 10 milliliter per day, about light green output. And other than that, abdomen is soft, no organomegaly, no other evidence of infection. Patient looks well.
Yes. So, like the history is suggestive of
Yeah, no, so you have 2 more minutes. If you have any more questions, you want to discuss with the patient, or you want to see whether you all are in the same page, you can have that 2 minutes. After that, I'll give you 5 minutes for the preparation. So you have 2 more minutes for the anything you want to ask from the patient, or any examination, or yeah, it's up to you. Two more minutes.
further, I'd like to assess the patient's cardiovascular system and also the respiratory system because it will be important for the further interventions of this patient.
Yeah,
So I'd like to
lungs are
know
clear. Yeah,
and
lungs are clear.
whether there
Heart, pulse rate, blood pressure. Their
yeah,
blood pressure is 140 by 90. Pulse rate is about 80. No other, murmurs or anything in your cardiac assessment.
okay, then
Yeah, if you are done with your history and examination, I can give you 5 more minutes for the preparation.
okay.
All right. So I think the other listeners also can have a summary or based on what Dul Khan inquired. So you can practice on that as well. So we'll give him 5 minutes and then we'll carry on with the. I'll first give a feedback and then we'll carry on with the discussion. So we are about 5 minutes now. Are you
Okay.
ready? All
Yeah.
right. So I'll first, before moving into the discussion, because as you all know, because now there'll be two new examiners will come and assess you based on what you discuss there. So they don't know how good you have taken your history and all. So be prepared for that. So before moving into that section, I'll finish about feedback about your history taking an examination. And the good things, you look confident and your pace is good, and you are not hesitant, and you are continuously inquiring. I think it's overall it's a good history taking. And about the negative things I realized in the history is that you can, when the patient is answering, you can give him some time to answer rather than quickly jump into the next one. So you can let him bit allow himself, tell himself what is happening, and so you can take a lot of clues from that, right? I mean, you did it well. I mean, I felt like uh, you were rushing into your next question, right?
Mm.
So if you can wait a bit more. So you did it nicely. So you started with open question. So you let me speak at the beginning and got some clues, and you carried on with your inquiry. That is good. But yeah, that's all right. And then about you would have asked more about the acute admission that I was trying to describe. So I said I had a ICU care. I was quite ill. So you could have asked more questions, right? And then whether I'm not sure whether you had any systemic inquiry because you were concentrating on these symptoms. So better to ask whether the patient has got any other symptoms, any other respiratory problems, any urinary problems, just to cover, because patient might come up with a new symptom, because we are all dragging on with this upper GI symptoms, the biliary symptoms, but you might miss a big problem that patient might have. So you also forget, patient might also forget because we are rushing. So better to have some sort of a systemic inquiry. You can at least ask, because you had about 2 minutes at the end. You can ask anything else that you forgot to tell me, or any other problem, any other problem in your body other than what we discussed, something like that. Yeah, have an open statement at the end also, just to make sure that you're not missing anything. Then other things about drug history. I'm not sure whether you asked whether the patient knows about the drugs that he is taking, because I said there's a significant history of diabetes, hypertension, ischemic heart disease, and I had difficulty in breathing. So this could be heart failure. So I wasn't sure whether you asked about anticoagulation, whether the patient is warfarin. We don't know. And better to ask the drugs whether he knows what he's taking, because if the patient is taking clopidogrel, we might need to stop it if we are planning any interventions, likewise, right? And you asked about allergies. And the important thing that you missed, the other thing is the performance status. So I was trying to describe a patient who has had significant comorbidities limiting his capacity. And because of this acute infection, he got worse. That's why he had to go to the ICU. So you should have asked some questions about the performance status at this point, because we need to take it from there onward. So we need to decide how fit he is for any intervention. You should have asked how far he can walk, whether he can, walk 2 flights of stairs, how does a med score, right? So that is very important in surgical history. I think anyone should understand that performance status is very important in surgical long cases, right? Because patient might end up with an intervention. Right. I mean, overall, you are good. I'm just trying to pick up things that you can learn from it. Right. So that is the feedback. So what I'm going to do next is to discuss. So I would not stop at 10 minutes, because this is a learning activity. So I would carry on. So in the discussion, I will be asking the questions that can be asked in this sort of a scenario. Right. So, and then we'll discuss how to answer that as well. So we learn something from out of it, right? Okay. So I think Dulhan will be the candidate to speak. Right. So this is the first question that you will be. I'm not the patient anymore. I'm the examiner, and so this is the commonest question that we ask. Tell us a summary, please.
So this is a 65-year-old male patient from Kahawatha, a former teacher with a med score of more than 4 and ASA grade 2, with a background history of controlled diabetes mellitus, hypertension, and episode of acute coronary syndrome two years back. This time presented with an abdominal drain tube inserted 1 month ago to the right hypochondrial region, following worsening of right upper quadrant pain for 1 month with fever and shortness of breath, and has had a ICU admission as well, which has been the pain has been there for about 6 to 7 months intermittently, lasting for about 30 to 60 minutes in each episode, and associated with nausea and vomiting, and with no other associated symptoms. His quality of life has been severely affected before the insertion of the tube, but the patient denies any new complaints now, and the symptoms also have been improved. On examination, there's a drain tube inserted to the right hypochondrial region, draining a light green color fluid of 10 to 15 milliliters collection in the bag. And also the other abdominal examination findings are unremarkable. Other systemic other systemic examination findings are also unremarkable.
Right. So it is very comprehensive, but I think it's a bit long because you have 10 minutes in the exam for the whole discussion. So I think it's a bit long. You can summarize it more. So what do you think what do you think about his problem now?
So he
What do you
has
think his acute admission he had 1 month ago?
uh, it is possibly due to acute cholecystitis.
Right. I think you can come up with the word, right? You can say the patient with the so you said a good background, medical background history, and then next thing you can say patient with a background of intermittent hypochondriac pain, most probably a biliary colic, acutely admitted 1 month ago with pain not resolving, most probably with an episode of acute cholecystitis. And during that admission, he got deteriorated, and because of that, he was transferred to ICU and probably had a drain placement to the gallbladder. Probably, what do you think about this drain? What do you think?
Percutaneous, percutaneous
Yeah.
uh, biliary drainage.
So, do you think it's a biliary drainage or something else? It's
So
fine.
it
We'll
could be
discuss. So actually, this is a
polycystic
gallbladder drain. So it's called percutaneous cholecystostomy. So we'll discuss as
cholecystitis.
we go on. So you can summarize. I mean, you don't have to tell the whole thing that the patient mentioned. I mean, you were trying to summarize, but you can do it bit shorter. So you can use the key terms. History of biliary colic, coming with acute episode, most probably acute cholecystitis, severe enough to go to ICU and had a drain placement. He's coming back for the review. At the moment, he is not having any symptoms and brain is functioning. On examination, these are the findings. Understood? Right? You
Yes.
can do it within 1.5 minutes. Right. Right. That's fine. So the next question is, what are the current problems he has got?
So the main concern of the patient is about the drain, like whether to keep it or to
Yeah.
remove the
So he
drain.
has a drain in situ, right? A drain that is drain in the gallbladder is in situ, right? One problem. What else?
Uh,
Yeah. So these are the problems I identify. So patient has, of course, symptomatic gallstones. Patient had a history of kind of a biliary colic, presented with acute cholecystitis, was severe enough to had a drain. So he has symptomatic gallstones. Agreed?
Yes.
Right. So the next problem, as you mentioned, he has a tube in situ. What are you going to do with it? Patient is also asking, right? That is the other problem. The third problem is whether patient has got any other gallstone related complications. This part also you missed in your long case. You would have asked about history of you. I mean, you asked. I mean, I wouldn't say that actually. It was a wrong statement because you asked about jaundice and you asked about pain related to pancreatitis. I think it's not. You did it. I mean, in a certain extent, yeah. So we'll discuss as we go on. And then the fourth problem is patient is you said ASA4. I think at this point he would be ASA3. So if you all are telling ASA, be thorough with what is this ASA number, right? So what is ASA for?
No, sir, I said SA2 because
ASA2. Sorry, I heard ASA4. Sorry. So what is ASA2?
he's having controlled diabetes mellitus hypertension. I thought like control
So ASA2
comorbidity.
is, yeah, if you read about ASA, ASA2 is patient with mild systemic disease. So this is a patient, 65-year-old, diabetes, hypertension, ischemic heart disease 2 years ago, and having some limitation in his daily activities. So this is severe systemic disease which is under control. So this come under ASA3 according to me, right? Right. It is surely beyond ASA2, right? So now we have the problem whether he is fit enough for any intervention. So that is one of our aims in surgical long cases, right? So we will take one by one, right? So we'll start with the ghost stones. So at this point, the examiner might go back to your basics, right? He might ask the basic questions. What are the types of gallstones you know? So I'm talking about possible questions. I'm not telling that these all will be come in your long case, but there are possibilities, right? What do you know about the types of gallstones?
So there are cholesterol gallstone, pigmented gallstones, and mixed gallstones. In
All right.
pigmented
Yeah.
is
What is the commonest type?
mixed gallstone, 80%.
Mixed gallstones. Right, these can come in your long, in your MCQs, right? So I think the commonest type is cholesterol stones. In the West, about 80% is cholesterol stones, right? So there, as you said, there are several types. So we divide these types based on the cholesterol percentage by weight and the color, right? So if the cholesterol content by weight is more than 80%, we call them cholesterol stones. Then if the cholesterol content is very low, it is less than 20%, we call them pigment stones. So pigment stones can be black pigment or brown pigment. Or else, as you said, if the cholesterol is between these two, we call them mixed, right? In Asia, compared to the West, the pigment stone percentage is more, but still the commonest stone is cholesterol stones even in Asia, right? Understood? Okay. So there can be few more basic questions. They can ask what is the pathogenesis of cholesterol stones? Any do you know any explanations? Any theories?
So like it can involve with uh, various factors like increasing concentration of cholesterol and
Mm-hmm.
stasis, and that will lead to nucleation of cholesterol crystals, and the stasis will further
Yeah, very good. Yeah. So
make
yes, very good. So what
that
happens is, yeah, because of increased production of cholesterol from the liver, maybe in certain situations like a patient with even dyslipidemia, obese patients with metabolic diseases like diabetes, the cholesterol production will be more. but the biliary salt content will be static. So this will be supersaturated, which will then kind of crystallize in a cholesterol monohydrate as a cholesterol monohydrate. So this will be the nucleation for the stone formation. In addition, gallbladder hypomotility can also be contributory. So even a patient with diabetes, in this scenario, this patient uh, diabetes and other more metabolic disorders can lead to even gallbladder hypomotility. That is one contributory factor, and cholesterol production from the liver may be high in this patient. But who's the typical we have this saying, the typical uh, you know uh, patients who get cholesterol stones, how do we describe them? This is a character, typical saying that we use in this gallstone disease.
So fat female in 40, fertile, and
Exactly. Yeah. So that is the category that who develop these cholesterol stones. Female, because of their hormonal problem, they will have high cholesterol production, gallbladder hypermotility, and then obesity is contributory. And because of pregnancy and all, they all attribute to this gallbladder hypermotility. So that is female 40, fat, fair. So that is a typical description of the people who develop cholesterol stone. Understood?
yes.
Right. Yeah. Otherwise, I will continue to speak. Right. So, do you know the pathogenesis of black pigment stones?
So it's mainly due to the black pigment stone, mainly due to because of the process of hemolysis and the biliverdine production and
Yeah, as you said, this is because of excessive unconjugated bilirubin. Unconjugated bilirubin is not water soluble. So water soluble is a conjugated bilirubin. So because of the conditions like hemolytic anemia, there can be increased production of unconjugated bilirubin, which can get precipitated, causing black stones. Right. So what is the pathogenesis of brown pigment stones?
so it's due to infection and production of inflammatory changes.
Yeah, yeah, good. So this is different from black stones. Even though they are pigmented, this is different. So the brown pigments are due to bacterial infections, rarely parasitic, plus biliary stasis. What happens is these bacteria produces various enzymes. These enzymes act on these constituents of the bile. So the conjugated bilirubin can get deconjugated. So the bilirubin can be precipitated with calcium, like calcium bilirubinate. And then there's another constituent called lecithin. Lecithin can be broken down to lysolecithin and fatty acids. So these fatty acids can get again connect with the calcium and get precipitated. So the color will be brown, right? So I don't think you will need to know in detail, but have some idea why these stones are, because this can be asked in your essays and even in your MCQs. Right. So we'll come to the clinical part, right? So you understood that this patient had some pain episodes. So you say you think it's a possible biliary colic, right? So in the exam, you can be asked, how do you characterize this is a biliary colic? What are the characteristics?
So it could be uh, right upper quadrant pain, uh,
Mhm.
the which is in which is a remittent type, like the pain doesn't come to baseline,
Very
and
good.
but with acute episodes of worsening of pain and
Yeah. If I'm to answer, I would start with this. This is actually not a true colic. This is a pseudocolic, or we call it a misnomer. So this can be even asked from you to draw in your exam. So as you all can understand, I hope you can see my cursor. So I'm showing a typical colic. So the typical colics are ureteric colics and intestinal colics. So these are crescendo, decrescendo type of pain, waxing and waning pain that comes to the baseline in between the episodes. But the biliary colic, which is not a true colic, it remains, having some pain intensity, even though the pain reduces, it does not come to the baseline. So biliary colic. So if I'm to explain a bit more, so when there's a gallstone blocking the cystic duct or gallbladder neck, the gallbladder contracts more and more to expel this, right? So that because of the stretch receptors and the mechanism receptors in the gallbladder gets activated, and patient gets pain. With the contraction, pain will be more. Between contractions, pain will be less, but does not come to the baseline. That is what is happening. So, but what happens at one point, this stone will disimpact, and patient will have resolution of pain. It takes about half an hour to about several hours. But what happens, Dulhan, can you explain me what happens during the last episode?
Like when the colic, the stone is obstructing the cystic duct, it can cause stasis, and infection can cause inflammation of the gallbladder, and it could lead to persistent irritation of the parietal pleura and cause the features of acute cholecystitis.
Yeah, kind of. So what happens is, as I told you, in the biliary colic, the stone it disimpact at one point and pain resolves. But imagine a situation where the stone is continually impacted. So what happens? The gallbladder produces mucus from the gallbladder wall. So this get accumulated and gallbladder get distended. And this distension can cause mucosal injury, and then there can be bacterial translocation and can get inflamed. That is what is happening with the acute cholecystitis. So the patient with biliary colic slowly changing into a infection situation or the inflammatory situation. So pathology changes. So initially patient had this sort of a biliary colic kind of a picture, but if the inflammation sets in, there will be a constant pain like this that is lasting more than 6 hours. That is how you differentiate biliary colic from acute cholecystitis pain. Biliary colic will settle in a few hours, but if the pain is persisting with other systemic features, we clinically think this patient has now developing acute inflammation of the gallbladder. Am I clear, or should I explain more?
Yes.
Right. If you have any question, you can ask, right? So that is how the pathology changes and the pain characteristic changes. So the biliary colic will become constant, prolonged pain. Right. Right. Now, patient said, and you understood that pain was radiated into the right shoulder tip. So why do you think so? What happens here?
That's because due to the irritation of the diaphragm and its referred pain, so the inflamed gallbladder can irritate the right hemidiaphragm, and it can radiate the pain to the right shoulder tip with the phrenic nerve, because the path of the phrenic nerve lies
Yeah, that's
from
good. You are
the
trying to describe it. So what this is the referred pain we are talking about. So what happens is, when there is some pathology in the gallbladder, maybe inflammation, maybe distension, as it is coming just out of the liver at the edge, so with the distension or inflammation, it can compress on the diaphragm, maybe lower fibers on the diaphragm. So when it happens, diaphragm get irritated and nociceptive receptors are carried through phrenic nerve. We all know the diaphragm is supplied by the phrenic nerve, as you correctly said. So this will come to the spinal cord C3, C5 level. So then it will, sign up with the second order neuron, which will take the stimuli to the brain. So we get the kind of a dull pain at this right hypochondria. But what happens is, if we think of our shoulder, dermatome, that is also supplied by C3, C5. So what happens is that nerve also goes there, the same nerve roots, and converge on the same second order neuron, because second order neurons are less than the peripheral nerves. So they may converge on the same one. So the same neuron goes up, and the brain is now misled, and the brain thinks that pain is coming from the shoulder tip instead of the diaphragm. So this is how the referred pain is explained. All right? Are you clear?
Yes, so it can radiate to the back as well, right? Like
Yeah,
this,
that is
you look,
kind of a similar thing, because that is I don't think the literally C3 C5, that is the muscle fibers in the posterior abdominal wall gets irritated when there is some kind of a ongoing inflammation, maybe some fluid, infective fluid. So that can be taken, the brain can be taken as the the level of the tip of the scapula. So that is why the pain is referred to there, right? But the diaphragm irritation is the phrenic nerve involved pathway of this referred pain, right? Right. Now, as you understood, the patient has had a tube inserted, right? So, what do you think the indication that patient had to have this tube?
uh, uh, for the acute cholecystectomy, the best management option is to go for a laparoscopic cholecystectomy. Either it could be done within 72 hours, or if the patient is presented later, we can do a interval cholecystectomy. So here in this case, the patient may be unfit for the surgical procedure. So maybe the drain has to be inserted to drain the obstructed system, and later when the patient is fit for the surgery, we can go for the surgical options.
Yeah, I think you are describing it more or less correctly. So what happens is, in cholecystitis, acute cholecystitis, uh, one nice to know thing for your level, I mean, just know the name. So we use these criteria from Tokyo guidelines 2018. I don't think anyone will ask these things from you, but nice to know. So we divide cholecystitis into three categories: mild, moderate, severe. So patients with mild and moderate, the current trend is to go ahead with the hot cholecystectomy. That is, we do the surgery during the same admission if we have the all the infrastructure. But what happens in Sri Lanka, we don't have that capacity. So what we do is we treat with antibiotic, and we let the patient settle with that, and then we discharge the patient and do an interval cholecystectomy. This is for a mild and moderate. But severe cholecystitis, that means patient has significant illness, systemic illness, maybe some organ impairment. So patient may not be fit enough for hot cholecystectomy. So at this point, we might try with medical management with broad spectrum antibiotics, but not settling. We need to have a way of temporizing the patient to get out of the acute situation. So as you correctly said, so it's kind of a severe acute cholecystitis which is failing to medical management. At the same time, I mean, if the patient is fit enough, this is kind of an individualized decision. Not each patient goes to the same pathway. If the patient is, very young and fit, we might even think of surgery. That is very individualized, right? But what happens is, patient because of the significant physiological derangement with the severe cholecystitis, may not be fit enough at that point. So we want to drain this infected gallbladder, right? So this is Dulhan, not the bile duct that we are talking about. This is the infected, obstructed gallbladder that we are talking about. So unless we drain this out, patient will not improve. So this is the simplest form that I show here that we have done here. So as you can see, I have drawn this in a way that it goes through the liver. Actually, it goes through the liver because imagine this tube was placed from the peritoneum. Imagine this is dislodged, all the infected content will get into the peritoneum. So what the radiologist does is he goes through the liver. So there's a good seal here. Even though it is dislodged, nothing will come out because of the liver. Understood? So this is percutaneous cholecystectomy with the ultrasound guidance. The radiologist put this in through the liver to the gallbladder. Don't mix this. I have some images. Right. So this is the cholecystosome because there can be various other drains coming out of right hypochondrium in your exam. But you can differentiate them with your history. So this is what you were trying to describe, right? So you can see the difference. This is called percutaneous transhepatic cholangiography guided drain. So here, the radiologist is draining the bile duct. So surely this patient must have had some sort of biliary obstruction. So the common way of decompressing the biliary obstruction is, do you know what it is, Dulhan? So if you want to decompress an infected biliary, obstructed biliary tree, what is the best access? The commonly used.
So we can do ER.
Imagine a patient with cholangitis. How do you drain the bile duct?
We can do ERCP.
Yeah, so the common way is ERCP. So imagine if the ERCP is not possible. Yeah. Am I being broken? My voice?
Yes. Yeah.
Can someone tell me? Is
So
my
we
voice broken?
Now
Yes,
it's
Upul, a little bit. Yeah. So, Dulhan, you just switch off your
yeah, I'll
video
also
then.
switch off my video. No?
So you can stay, Upul.
So I'm not broken, right? Oh, am I broken too?
Now it's all right. Now it's all right.
Okay, okay. Let me know if I'm not clear. Thank you. Right. So if there's a obstructed biliary tree, patient will have jaundice. If the patient is infected, patient will have features of ascending cholangitis. So it's a Charcot's trial. So the option that we use is ERCP. Imagine the ERCP is not possible, then radiologist can have a chance of doing it anterograde. So they will go through the skin with the ultrasound guidance, they will go through the skin and they will find a dilated bile duct and cannulate that and pass a tube in. This is to drain the bile duct. So this is called percutaneous transhepatic cholangiography. This is the procedure and through that they can pass a tube. So this is not this. This is again ultrasound guided gallbladder drain. So you need to differentiate that. And there's another one. Is Dulhan here or gone? All right, Dulhan. Yeah. There's another tube that you can find in certain patients. So this is T tube. This is completely different from these two. So this is kind of a silastic tube that is called rubber tube. These are generally plastic tubes. And this is a T tube that is placed after common bile duct exploration surgery. So we repair the common bile duct over a T tube to prevent blowout of the repair. Right? So this is beyond this discussion. I think there will be a separate discussion for you guys about the obstructive jaundice. I think there will be some discussion about these things. So I just want to show the difference. So I'm talking about the first one. This is just to decompress the gallbladder, not the biliary tree. Are you clear, Dulhan?
Yes. So in the history, if you are going to differentiate, the patient is having obstructive features, we think of this percutaneous transhepatic
Yeah,
cholangiography tube.
imagine a patient with history of obstructive system, patient with obstructive jaundice and history of kind of a loss of weight, loss of appetite. We are thinking of possible cholangiocarcinoma, pancreatic head cancer. And if this patient had this sort of a tube, we don't think it is to the gallbladder because before the surgery or as a palliation, the doctors are trying to decompress the obstructed biliary tree because of the cancer. Understood?
Okay. Yes.
Yeah, that is so. In this situation, we don't drain the gallbladder. So this is a different situation. So this the scenario that I'm describing is so evidence of jaundice. There's no place that you need to put a tube to the bile duct, right? You can clarify that with the history. Are you clear?
Yes. So we can do
All
it
right.
internally as well, right?
I didn't get that.
We can do this internally as well, right? Like without extra, like percutaneous
You
drain into
mean gallbladder?
gallbladder drain into the duodenum or the stomach.
No. This patient now, imagine this patient who's systemically ill, not fit enough for a gallbladder removal. I
Yeah.
don't think we
In
should do
this
any
patient,
any
there's
bypasses.
there's option like that, right? Not in this
No,
patient, but
not at this situation. But if you want to drain the gallbladder, there you can do, these are called cholecystoenteric fistula, kind of a anastomosis. But very rarely we do that. If we want to drain the bile duct, we attach the bile duct to the bile duct. We remove the gallbladder and attach the bowel to the bile duct. So we call we call hepatico enteric anastomosis, right? Or colidoco-enteric anastomosis. Very rarely we do cholecystoenteric anastomosis. These are for very, significantly, patient with significant metastatic burden. If you have no access to the bile duct, if you really want to decompress, we can put. I think this is beyond your kind of a, your level. If the patient is acute ill with acute cholecystitis, if the patient is not fit enough, you should do a kind of a tube drainage, not internally. Okay?
okay.
All right. Okay. Right. Now they can ask, examiner can ask questions about, because you are at the aim of this exercise is to make you a house officer. So they might ask questions to see whether you have the knowledge of a house officer. So he will ask how to care a patient with percutaneous cholecystostomy at ward. What do you do if you are the house officer?
Mm. So I'll first educate the patient regarding this procedure and about the
No.
catheter.
Patient has had the percutaneous cholecystostomy. How are you going to care him?
We have to do the proper catheter care, uh, to avoid any infection and dislodgement, and also monitor patients' inflammatory markers to pick up early and
Yeah, I
uh,
think you're trying to describe well. So we need to make sure the tube is secure. Generally, the radiologist, once they put the tube, they will secure it very nicely. But it is our duty to make sure the tube is secured well, and there will be a securing stitches, and there will be a dressing also that is also being placed to the tube. So make sure that the tube is secured, and every day you need to monitor the volume and the color, and if and daily we can flush, as with the aseptic technique, kind of a 10 milliliter sterile saline to make sure it is not being blocked. And then, as we all understand, the patient is systemically ill, need to continue antibiotics, and we need to clinically see whether the patient is getting better or worse. Right? As the infected collection is now getting drained, patient should come, generally get well. So we need to monitor it clinically and biochemically. That means the inflammatory markers. Then this patient because of the systemic infection and hospital admission, systemic infection can compromise his nutrition, but we need to make sure he's getting adequate nutrition. Then patient is significantly having comorbidities and with acute decompensation, you need to make sure you are monitoring for those comorbidities and optimize them, right? Okay. So the other question, now imagine, so as our patient who got better with this your medical management and ICU care, he was sent back to the ward from ICU and you are going to discharge with a tube. So what are the advices you are going to give Dulhan?
So we have to like instruct the patient to keep the insertion site clean and dry, and if there's any signs of infection, they need to get help from the healthcare team, and also secure it without pulling, twisting, or kinking the tube. And also about the drainage bag, he has to check whether the drain is the volume and the color of it, if there's pus or blood, they have to inform the healthcare team. And also avoid the strenuous activities like lifting weights, and also doing strenuous exercises, and to maintain proper hydration and also nutrition after
Yeah, that's
discharge.
good. Yeah, that's good. So, and one more thing, we need to teach the family members and the patient how to do the flushing, how to do it with the sterile saline. So we need to train them. If they are not competent enough, we need to arrange kind of a peripheral nurse to do it at least every other day, something. Otherwise, the tube get blocks, right? So we need to whatever you mentioned is correct, and we need to add this as well. And then we need to make sure that we are going to follow up this patient. We are not going to lose this patient with the tube in the abdomen. So we need to arrange follow up, because in an interval we need to monitor the we need to assess the patient clinically, biochemically, and arrange the next investigations to go to the next step. So that is where the patient is now. Patient has come back after 4 weeks from his initial problem. Now he has a tube in, and we are going to assess him and do the definitive management. All right, okay. So here, yeah, this is the question. So now how are you going to assess? Now patient is here, you got the history, now you know the background. So from this point onward, you have done the clinical assessment. Patient is clinically well at this point. What are the other assessment you are going to do?
So we have to assess whether the cystic duct is patent or not, to get the decision of keeping the tube or to remove the tube. And also we have to assess whether the patient symptoms has been relieved or still persisting, and signs of any complications.
Yeah. So as you have already done the clinical assessment and you have detected that he does not have any ongoing symptoms, and there are no evidence of biliary obstruction, he is not having any obstructive jaundice or fever, and then we need to follow up with the, so we start from basic investigation and go ahead. So blood investigations, we need to make sure that we do inflammatory markers, the counts, and liver functions to see any biochemical evidence of biliary obstruction, even though it is not clinically apparent. And we need to see albumin levels, hemoglobin levels, about his nutrition level, and baseline other organ functions like serum creatinine and electrolytes, right? And then we can have an ultrasound scan abdomen to see whether gallbladder, what is the current status of the gallbladder, whether it is still edematous, whether there are any significant fluid around, any abscess, any other local complications. Other than that, the radiologist can assess the biliary tree, any biliary dilatation, to see any stones that has gone to the bile duct, right? Then we need to make sure this patient has significant comorbidities. We need to arrange additional investigations because patient is having significant exercise limitation. So we need to arrange additional investigations like ECG, 2D echocardiogram because this patient might go ahead with an intervention. Right. So then, as you said, we need to do a dye test we call tube cholecystogram. So we inject dye through the tube to see the biliary tree. Right. So you have already mentioned why we do it because we need to see the patency of the cystic duct and we can assess at the same time we can assess the biliary rest of the biliary tree whether we can see any CBD stones, right? So this is a very nice cholecystogram. So you can, Dulhan, are you here with me?
Yes.
Yeah, right. So this is a very nice cholecystogram. You can see the tube is going into the gallbladder. So this is what I mentioned. So this is not in the bile duct, right? So you
Yeah.
need to appreciate that. So we inject dye through this. So the whole dye will pass through. If the cystic duct is patent, it will go to the bile duct and it will go to the duodenum. You can see the duodenum is, I hope you can see my cursor. So this is the duodenum that shows some, sorry, am I being broken again?
No, sir.
Okay. All right. Sorry. I was talking about dye. So dye has gone to the duodenum. Dulhar, can you see the duodenum here?
Yes.
Right. These are the mucosal folds. So this is the duodenum. So dye has gone from gallbladder to the bile duct to the duodenum. So this is a patent system. So cystic duct is surely patent and you can see for any problems in the bile duct. So you can see bile duct is not dilated, no filling defects to suggest of CBD stones. So this is a very good tube cholecystogram. Understood, right?
Yes, sir.
Okay, right. So as you mentioned, so we need to make a decision. So imagine now you have done the fitness assessment again because now patient has improved and he has corrected his physiology over 1 month and nutritionally optimized, comorbidities optimized. Right. If the patient is fit now, what is the management? What is the definitive management, Dulhar?
So we have to go ahead with the minimal invasive cholecystectomy. That means laparoscopic cholecystectomy after 6 to 8 weeks of symptom resolution.
Yeah. So only problem with that answer is now patient had a significant inflammation around the gallbladder and he had this tube placement. Doing a laparoscopy may be a challenge. But as you correctly said, we should try, but we might fail. The chance of conversion to open is very high. As Dr. Anurad is also here, he will also agree. So there's a very high chance we need to tell to the patient, there's a very high chance that we might need to do it open. But we start with laparoscopy as you correctly said. Right? So we can keep the tube till that time and we can surely remove the tube as we remove the gallbladder. So this is what we do if the patient is fit. Understood? Right. So here comes the
Yes.
problem. So patient continues to be unfit. So we do the assessment, patient is still not fit. So here comes the importance of tube cholecystostomy. So we have done the the tube cholecystogram. So we have done the dye test. So now we have seen that the cystic duct is patent, right? So that means the gallbladder is draining to the bile duct correctly. as the normal physiology. So now stones are there, patient is not fit to have the gallbladder removal, but the gallbladder is draining inside naturally. So you can remove the tube after 4 weeks, because now the track is formed around the tube. The track is formed, so you can remove the tube. Gallbladder will drain slowly into the bile duct. So imagine if the cystic duct is not patent. I'll show you once I tell you. So imagine the cystic duct is not patent. That means patient has kind of a chronically inflamed gallbladder with stones in it. Now there's no way to drain it other than the tube. It is not draining inside. So now if you remove the tube in this patient, surely he will have another infection very soon, because the gallbladder is continuous to produce mucin, and he has in gallstones. They are for kind of a nidus for infection. So patient will surely have another episode of infection very soon. So you need to keep the tube long term to prevent further attacks. So that is why. So let me show you what I was telling. Right. So imagine now this patient, the dye is not going to the bile duct or duodenum. So that means dye is only staying in the gallbladder. That is, cystic duct is not patent. So the tube is the only way out of whatever inside the gallbladder. So gallbladder has stones that we can't remove, unfortunately, because patient is not fit enough. So the duct is the only way that we can take all this out if it gets infected. Right? So I hope you understand. So if the patient is not fit, if the cystic duct is patent, we can remove the tube because it is naturally draining into the bile duct. But if the patient is having the not patent duct, surely we need to keep the tube long term to prevent further infections. Right. And then these are very general questions. I hope you all, yes. Sorry.
So
Did you ask anything? Sorry.
the disadvantage of keeping the catheter is like, is it infection?
Yeah. So imagine now I'll go back to the right. Imagine now you have done the dye test and dye is not going to the bile duct. So that means dye is only staying in the gallbladder. That is so kind of a blind ending pouch. Understood? Right.
Yes.
If we remove this tube, what will happen? Now you have a blind ended tube in your abdomen with gallstone in it, and gallbladder is producing mucus every day. There's no place that it can drain out. Initially, it can drain out through the tract, but tract will obscure in few weeks, well, maybe few days. So you have a pouch inside the abdomen. It has no place to drain, and it has gallstone in it that we can remove surgically, and it is daily producing mucin. So what is the scenario? What do you think will happen?
Acute cholecystitis.
Yeah, he will have further attacks of acute cholecystitis because it is
No,
not.
so what I asked was like, if the cystic duct is patent,
All right.
can't we keep the tube as well, because it can like block again and goes.
Yeah,
Because we
I
are
mean the
getting
best option
cystic-
here is removing the gallbladder. There's no doubt about it. So no problem at all. But if the patient is not fit, having a drain in is not easy. So we need to think about patient quality of life. As you said correctly, if once we remove the tube, patient can have further episodes of cholecystitis that we need to discuss with the patient. But I don't think anyone will be happy to keep this drain for a long time, and these are plastic drains and these can come out, there can be dislodgement. So it's not easy to take care of this drain. So I mean, if the patient is symptom free, and in after the dye test shows patent cystic duct, I don't see a reason we need to carry on with the tube. But surely, if patient develop another episode, we might need to drain it if the patient is severe enough, not settling with antibiotic, or else we need to discuss with the family. That is, these are very extreme situations. Discuss with the family, discuss with the patient. There's a very high risk of dying of this surgery, and take the risk and do the surgery. Likewise, so these are extreme cases. I don't think you need to go there. So just remember the principle behind it. All right. Okay. Right. So this is very generic question. I hope you all can answer this question. As the time is passing, I will quickly rush through. So always you need to classify, divide and mention specific and general complications. Specific ones you need to first mention about early complications and late complications, bile leak, bile duct injury, bowel injury, conversion to open. In this scenario, this conversion to open is very high, and then there can be retained CBD stones and post cholecystectomy syndrome. And other than that, there can be general complications, bleeding, infection, DVT, anesthetic complication, incision, hernia. So post cholecystectomy syndrome, do you know what it is, Dulhan?
Quite sure.
Yeah, so these are kind of a bit advanced questions for medical student level, but I think you can have have a look, at least have an answer of a one sentence. So these are collection of symptoms that patient might develop after cholecystectomy. Patient might have similar less severe pain at the same place. Patient can have other symptoms like dyspeptic symptoms, loose stools, even after gallbladder removal surgery. So these collection of symptoms we call post cholecystectomy syndrome. Yeah, so just have a prepared answer for at least one sentence. Okay. Right. So imagine if we keep the gallstones in general in any patient, what will happen? Dulhan, you have a patient with gallstone, what will happen? What are the possible complications other than biliary colic that we discussed?
So it can cause recurrent episodes of acute cholecystitis, and it can lead to chronic cholecystitis, and these stones can dislodge in the common bile duct, and also cause acute cholangitis, which is life-threatening, and also ascending cholangitis, and these stasis, the obstructive system can cause complications like gallbladder empyema, and rarely it can lead to perforation, but it's very rare, and also can cause gallbladder pancreatitis by dislodgement of this sphincter of body with the gallbladder stones, gallstones, and also gallbladder ileus as well. By
Yeah, good. Yeah, good. When you list, try not to explain as you list, then you get confused. So just list it first, and then examiner might ask few more questions, then take it from there. So you can just list first. So if we talk in general, any patient with gallstones will not cause these complications unless they become symptomatic. So in other terms, if the patient is asymptomatic, imagine we have detected gallstones incidentally, we have done a scan for something else and we have seen gallstones. Generally, we don't operate unless there are few other indications like porcelain gallbladder, or patient with hemolytic anemias, or patient who are doing high risk occupations like pilots, sailors, likewise. So unless the patient is symptomatic, we don't operate unless patient has these other criteria. So once the patient becomes symptomatic, they have a very high chance of having recurrent symptoms or having this list of complications. So, as he correctly mentioned, patient can have acute inflammation of the gallbladder, we call acute cholecystitis, and its sequelae. Sequelae means it can get infected, it can get empyematous, then wall can be gangrenous or else perforated. So, empyema, wall gangrene or perforation. So those are the sequelae or resolution of mucocele. So those are 5 sequelae of acute cholecystitis. Then, as he correctly said, gallstones can cause gallstone pancreatitis. Um, it is another complication that can be very severe. So you should ask these things in the history whether the patient has had any of these complications in the past. Then, as he correctly said, stones can dislodge into the bile duct, can cause jaundice or superadded infections, we call cholangitis. And then the duct in the cystic duct, the stone in the cystic duct or the neck of the gallbladder can compress on the bile duct, causing proximal biliary dilatation, we call Miritz syndrome. And other than that, there can be chronic inflammation of the gallbladder, can lead into cholecystoenteric fistula, leading into stone passing into the small bowel. If the stone is big enough, it can block at ileum, resulting in gallstone ileus. This is a bowel obstruction, right? So this just know this list and few details about it. Right. So this is about the discussion that you can get around gallstone disease case. So I will show 2 model MCQs to wrap this up. And then we'll go for the questions if you have any. So, Dulhan, sorry, I'm asking from you because I don't think others are going to speak. So, sorry about it. So, MCQ, this is a pattern you can get in gallstone disease. Dulhan, any idea about the answers?
Yes, the first one is false.
Very good. Yes.
Commonest gallstone, pigmented stones, false. It's cholesterol
Yeah.
stones.
Cholesterol stones. Yeah. Very good.
It can cause various complications in true.
Yes. 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 We just
Acute
discussed. Yes.
cholecystitis can occur without stones. Yes, there's an entity called acalculous cholecystitis.
Yeah, let me tell about it. Yeah, that is good. That is correct. So this is called acalculous cholecystitis. The commonest scenario, 98% of the time of acute cholecystitis is due to stones. So you do a scan and you see stones. So you need to know few features of acute cholecystitis with ultrasound scan. So one is wall thickness, increased wall thickness, pericholecystic fluid, and other thing is stones inside the gallbladder. So this is called acute calculous cholecystitis. But there is another situation. We have cholecystitis without stone. This is called acalculous cholecystitis. So this is completely different from calculus cholecystitis. This happens as a part of systemic illness in severely ill patients. Patients who are in ICU, patients who are in severe sepsis or severe systemic illness, patient with burn. So because of general kind of a general circulatory instability, the gallbladder is also kind of getting generally ischemic. So that is the scenario that is where the gallbladder gets inflamed. But it is not due to a problem in the gallbladder. Remember that it is a part of systemic illness. So there is no place for cholecystectomy in this patient. But imagine this patient get worse and worse due to acalculous cholecystitis. This patient you can do again a drainage. Percutaneous cholecystostomy is the management of worsening acalculous cholecystitis. But imagine this patient recovers, and after that, there's no place for laparoscopic cholecystectomy this patient because patient gallbladder has no any problem. Because of the patient's systemic illness, he got this gallbladder problem. Understood?
Yes.
Right, right. E?
True, sir. It's what we called hot cholecystectomy.
Yeah, so this is now the trend, but you may see a lot of patients who are having interval cholecystectomies in our setup. That is because we don't have the infrastructure. All right?
So excuse
Right.
me.
Yes.
What is the duration for hot cholecystectomy? Is it like 72 hours or we
No,
can?
no, that is wrong. So initially they said, when the concept of hot cholecystectomy came into place, they were doing various studies and shows 72 hour is the cutoff. Other than that, patient the outcome will be poor. Now we have new researchers showing there's no time cutoff during the admission. Doesn't matter whether 5 days, 6 days. If you can do it, you can do it. So this is, I don't think anyone will ask from me, but there's no 72-hour cutoff. If someone is asking that, that is wrong. There's no 1 day to 70. So the 72 hours is the commonest cutoff that they're talking about, but it is not. Even after 5 days, if you are competent, you can do it.
Okay.
Right? Right. Right. So this is SBA format. Do you
So
think?
shall I?
Yeah, try.
36. So we have to go with MRCP followed by ERCP.
Why MRCP? So liver functions normal, CBD not dilated. Why do you think you need MRCP?
No, sir.
Yeah, only problem here is A and D. A is what we generally practice, IV antibiotic, and then once the patient recovered, we discharge and do elective cholecystectomy. And D is what is the current trend, early laparoscopic cholecystectomy during this admission. Actually, in my mind, I wanted to put this as early open cholecystectomy, but unfortunately, I have put it as laparoscopy. So if it is open here, so all of you forget about laparoscopy and think as early open cholecystectomy during this admission. What do you think about it? So this is a mistake from my side. So the statement D is early open cholecystectomy during this admission. So what do you think? A or D?
A.
Yeah, because open cholecystectomy is not the procedure by choice. So we always plan laparoscopy and we might end up with open. So if this says early open cholecystectomy, we don't do that. We do early laparoscopic cholecystectomy as hot cholecystectomy. We might fail and we might need to convert. But if this says early open, because we never plan open cholecystectomies except few situations, right? So in that case, if this says early open, we should go ahead with this and do this later on. I hope I did not make you confused, right? Okay, I think this is about it. And if you have questions, I'm more than happy to answer. Where should I check questions? Sorry. Uh, Dr. Anuradha, are you here?
Yes, I'm here.
Should I check there are 11 chats. Is it for me?
No. Just I think one has asked, can you explain with more? So I think that you have explained after that, right? So the second one I answered. So you
Okay.
also later on explain. So if you have any question right now, you can. It's better to ask rather than just. Okay. What are situation we going for open cholecystectomy is asking. I mean, you mentioned that there are few situation we are
Yeah.
doing open cholecystectomy in a early situation. So they ask about what are the situations we go in for open cholecystectomy.
So the main indication for open cholecystectomy as a planned one is gallbladder cancer. So in that case, we generally go as open and we do a radical cholecystectomy. But for all other gallstone related problems, if imagine,
One other thing would be maybe
yeah,
smart
significant
abdomen, like
additions, yeah,
previous multiple
yeah.
surgeries, no side
Yeah, that's what I'm
point.
going to tell. Yeah, previous multiple upper abdominal surgeries that might, hinder the access. So that may be another situation that we might plan as open. Other than that, most of the time we try laparoscopy and we might fail to convert to open.
And the other question is, what are the situations we use EBD? External
Actually, it is
biliary.
not the relevant question for this discussion because this patient never had biliary ductal problem. All the problem he had was infected gallbladder related problem. So EBD, as I showed in one image, let me try and show you. So yeah, so
Sure.
EBD is kind of a PTC guided drain. So this is the situation where we have an obstructed biliary tree, bile duct. We don't have an access from the ERCP for some reason. We may try and fail. Then the radiologist, with the ultrasound guidance, he passes a tube through to the intrahepatic ducts and through that pass the tube to the bile duct. This is called external biliary drainage. So today's discussion is about percutaneous cholecystostomy that we drain the infected gallbladder. So these are two complete different scenarios. So EBD is a situation where you have a bile duct obstruction that you want to relieve the obstruction, that you don't have the access from the ERCP. So then radiologists might try through the liver as anterograde. So ERCP is retrograde, that you come from distal end to the proximal end. This is anterograde. So this we first do the cannulation of the intrahepatic duct and go anterogradely to drain the bile duct. So
Right.
this is a scenario where you have bile duct obstruction. Yeah.
The next question is, what are the sorry, what is the choice of antibiotic in acute cholangitis and cholecystitis?
Yeah, both are infective because today I discussed mainly about acute cholecystitis. So acute cholecystitis initial bit may be inflammatory, but soon it will become super infected with the gram-negative bacteria. So you need to cover gram-negative bacteria when you treat acute cholecystitis. So the common ones are, piperacillin tazobactam, or else if the patient is not that ill, you can start with second generation cephalosporin. But ascending cholangitis is kind of a severe kind of a situation, toxic situation where you get severe inflammation involving the bile duct and all the intrahepatic small ductules. So it is not like cholecystitis. Sorry. Sorry. Cholecystitis, you have the infected surface of the gallbladder pouch. But cholangitis, if you can imagine, it is infecting all of the bile ducts and all these small intrahepatic ducts. So if you open up the whole surface of the biliary tree, it will be like a football ground, the surface area. So the systemic toxicity is very high in ascending cholangitis than cholecystitis. So you need to be very vigilant, and because patient might go into sepsis and septic shock early than cholecystitis. So again, gram negative, sorry, good antibiotic you need to give, maybe piperacillin tazobactam. Sorry about it. Anything else?
Next question is, what are the instances going for ERCP plus stenting before elective cholecystectomy?
So ERCP plus stenting. I mean, if you have a patient, sorry, I'm getting cough again and again. Yeah. So now this is the patient that has got some other complications related to the gallstone disease. So let me come to that slide. Uh, right. This is the slide. Now, so you have a patient with gallstones, and surely it is involved in the bile duct. So maybe a stone has gone to the bile duct. Sorry. So you have the patient with gallstone disease, and surely he may have passed the stone to the bile duct. So we need to address that first before removing the gallbladder. So imagine a patient has clinical or biochemical evidence of or radiological evidence of a stone in the bile duct. We need to do uh, imaging. I mean, if it is not clear in the ultrasound scan or CT, we might go ahead with the MRCP, because in Sri Lanka it is not a easily accessible imaging. And then if there are stones in the bile duct, we need to remove them through ERCP, and then only we go ahead with the gallbladder removal surgery. That is one instance. Or else, imagine a patient with Miritzi, that is a stone in the cystic duct compressing on the bile duct. So in this situation, again, we might need to do ERCP and stenting, but we may not do a straightforward cholecystectomy. It will be a removal of the gallbladder and repair of the bile duct wall. But the general indication is, if there are stones in the bile duct, we remove them with ERCP. If we are satisfied with the stone removal in the bile duct, we don't need a stent. But if you are not sure, we can keep a drain and have a relook later on. Then followed by gallbladder removal surgery. Any more questions?
Yeah. Sir, could you explain a bit more how to differentiate moderate acute cholecystitis and acute severe cholecystitis? They're asking about, I think,
Yeah, this is, I mean, you can easily check because generally what you need to describe is clinical and biochemical features. So clinically, patient will be having significant systemic illness. In addition to the clinical symptoms, patient will have hemodynamic instability, and biochemistry will be showing very high CRP level, WBC levels, and maybe organ impairment. So if you want to really check what are exact criteria, you can just Google uh, Tokyo Guidelines 2018. So it will show features of mild, moderate, severe. But we don't generally go there, but we just discuss the mild symptoms, moderate symptoms, and severe symptoms is organ failure.
So if you have any other question, you can drop that into the chat box. Right. As there are no any other question, I think we can conclude the session. So on behalf of Wayamba University and the Rajarata University, I would like to thank Dr. Upul De Silva, senior lecturer and consultant general and HPB surgeon, for your very nice presentation on gallstone disease and how they question in your long cases. Thank you, Upul, for your valuable time and effort. Thank you. See you
Thank
again.
you for the opportunity, and I would wish all of you all the best for your upcoming exam. Thank you so much. Thank you, Dr. Anurad. Thank you,
Thank
Dulhan. Thank you,
Thank you very much,
and
sir. It
well
was
done.
like
Yeah,
very
well done.
good
Yeah,
evening, sir. Thank you, sir.
yeah.
We'll
So,
give you a distinction for that discussion, right?
yeah.
Okay.
Okay.
Thank you, sir.
Thank you. Good night.